Cardiac myxomas and cardiac papillary fibroelastomas comprise the two most common primary cardiac tumors. They are each rare in and of themselves in their incidence, and they are both differentiated from each other through histopathological morphology and their location on the cardiac structures. Papillary fibroelastomas are most often found on valvular surfaces, such as the mitral or aortic annuli, whereas most cardiac myxomas occur in the left atrium with about 75% incidence, followed by the right atrium with about 18% incidence, and the left and right ventricles with about 6% incidence in total. Less than 1% of cardiac myxomas have a valvular origin. We present a case where a cardiac myxoma manifests in its rarest location, the non-coronary cusp of the aortic valve. A 51-year-old woman was hospitalized 4 months prior due to a cryptogenic posterior circulation cerebrovascular accident, and she presented with tongue heaviness. CT angiogram along with perfusion studies and transthoracic echocardiogram were both unremarkable. A mass-like structure that measured 0.4 by 0.5 centimeters was discovered on the aortic valve after she underwent transesophageal echocardiogram, and this was denoted to be a small Lambour's excrescence. The patient was discharged on medical management, including antiplatelet therapy, and she had an implantable loop recorder placed. The implantable loop recorder revealed no atrial fibrillation or flutter, and the patient had no residual deficits after her discharge. She returned to the emergency room 4 months later with similar focal neurologic deficits, including the tongue weakness. However, this time also attested to left-sided weakness, dizziness, headache, vertigo, nausea, and emesis, all of which promptly began 30 minutes prior to her arrival. She endorsed compliance with her home medications. A stroke alert was immediately activated, and she received TPA after her non-contrast CT scan ruled out intracranial hemorrhage. CT angiography and perfusion findings on her second hospitalization were once again unremarkable. She underwent a second TEE, which revealed a pedunculated mass-like structure originating on the non-coronary aortic valve cusp. However, it had increased in size from her prior hospitalization. This time, it was 1.0 by 0.7 centimeters, compared to the 0.4 by 0.5 centimeters on her prior study, and this mass-like structure was identified as the source of her recurrent emboli. Cardiothoracic surgery was promptly consulted, and the patient underwent mass resection. Per the surgical operative report, the majority of the tumor visualized on the TEE had embolized. Thus, the remaining mass and stalk, which was connected to the ventricular side of the non-coronary aortic valve cusp, was removed and sent for pathological examination. Initially believed to be a papillary fibroelastoma from the TEE findings, simply due to its location and morphology on echocardiogram, the path report confirmed otherwise. The pathology report described a pale tan fibromembranous tissue fragment measuring 1.7 by 1.2 by 0.2 centimeters and denoted this to be a cardiac myxoma. Fortunately, this mass had not grown extensively, as myxomas are notorious for doing so. The patient underwent successful mechanical aortic valve replacement, atrial septal defect repair, and left atrial appendage ligation. She was subsequently discharged on her home medications as well as warfarin for the mechanical valve. 6 months later, she continues to follow up routinely with outpatient cardiology. She had a repeat echocardiogram done 3 months after her discharge, which showed no evidence of recurrence, and she has had no neurological sequelae since. She will continue to be monitored with serial echocardiogram due to the high recurrence rate of cardiac myxomas. Cardiac myxomas are rare, benign tumors derived from multipotent mesenchymal cells, causing clinical symptoms such as syncope and stroke due to the wrecking ball effect they possess. This case describes a unique presentation of cardiac myxoma while highlighting the importance of a thorough investigation and reinforcing the benefits of reviewing prior imaging studies. It also highlights the importance of maintaining a broad differential diagnosis when evaluating our patients. Thank you.